Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Oh, good evening, John. How are you?
Good evening, Jay. How are you doing today?
Okay.
How is beautiful California?
It's nice. It's a little windy. It wasn't not as windy as it's been the last few days, but it's nice. We had a heat wave, and then it was cold, and now it's kind of in the middle.
It's just beautiful here in Hattiesburg, Mississippi. I got to ask you, Jay, both of us were lecturing this weekend. How did your lecture go, my friend?
Oh, great. I was in Denver, the Denver Implant Study Club, and I talked about guided implant surgery. And that was great. About 40-something doctors there, and met a good number of them, and it seems like a really good group. Where were you?
I was in Portland, Oregon, Jay, at the Oregon Dental Conference.
Oh, I've spoken at that.
Great conference. I had a full house.
Mm-hmm.
I talked on advanced medical emergency training and preparation. And Jay, I'm telling you, I had a phenomenal group. This group of dentists and hygienists and assistants, you could just tell these people want to know this stuff.
Yeah.
They felt like they had never really had a good training in this. And you know, Jay, you and I have talked about this on the show before. All it takes is one event.
Yeah. That's just one. That's all you need.
Just one. And you know, it's either going to be career defining or career ending.
Right.
And there's a lot of dentists out there that just do not take this matter serious.
Yeah.
They believe just syncope is going to happen to them. And then, you know, that's only makes up 50% of a study that was done in 1993, Jay. That's how antiquated it is.
Oh, really?
Yes.
Yeah. I mean, it's probably still the number one, but but now as people are getting older, living longer, I mean, certainly in my practice, I have more and more unhealthy patients coming into my office that want to have treatment under IV sedation.
And you know, Jay, the thing about it, you know, after every one of my lectures, and I'm sure the same with you, I always invite my audience, come up, talk to me, tell me, you want to tell me something. And we had a large contingent of people. In fact, I thought I was going to miss my connecting flight because I'm looking at the number of people lined up. Everybody wants to tell a story that happened in their office.
Yeah.
All right.
And most people, if you've been practicing long enough, you're going to have one or two.
Yeah, you are going to have them. All right. And I'm just here to tell everybody listening, they are not rare. Do not take that attitude. So
get trained in medical emergencies because they will happen in your office.
And stay trained.
Yeah.
All right.
Stay up to date.
Yeah. Because I mean, like the course that I put on, that's a great foundation, but you got to build upon it, Jay, and just keep going. You know?
Yeah. You got to reinforce it or you forget.
Hey man, since we last talked, 5 new drugs have come onto the market. Can you believe it? 5.
Wow, 5. Boy, what could they be?
Well, it's interesting. You know this is going to happen.
Any Janus kinase inhibitors? Any monoclonal antibodies?
Yeah, it's going to be some monoclonal antibodies. In fact, Jay, I was so thankful that you and I talked about this because you know, during my lectures, and I'm sure yours too, when a hand goes up, anything can get brought up. And we were talking about steroid cover.
Right.
And then someone brought up about immunosuppressants. And I sort of just chuckled a little bit. I said, well, you got to make sure you cover these patients with antibiotics. And one of the biggest drug classifications out there that's coming onto the scenes are the MABs, the monoclonal antibodies.
Yeah, they're very popular.
Everybody was they were just
coming out for just about everything, just about every disease.
Yes, which is great for everybody. Okay, you know, like our first one is a UMAB, and of course, MAB stands for monoclonal antibody.
Right. Yeah,
but Alymsys, ALYMSYS, and I mean, it just got approved. But Jay, this drug is a vascular endothelial growth factor inhibitor and is very similar to the drug Avastin. Okay. Now, I'm going to read out to our audience, Jay, everything that it's indicated for.
Okay.
Colorectal cancer, non-small cell lung cancer, glioblastoma, renal cell carcinoma, cervical cancer, ovarian cancer, fallopian tube cancer, peritoneal cancer. Jay, look at the broad range.
Yeah. They almost have surface protein or something in common that it's directed. The antibodies are directed against.
That's correct. And, like I said, it's a biosimilar to Avastin, which is also interferes with the growth and spread of cancer cells throughout our body. All right. So like, for example, with metastatic colorectal cancer, Alimcyst is used in combination with fluorouracil. Okay.
Okay.
So this is giving you or your loved ones another chance at life. All right. Because cancer affects all of us.
Yeah.
Okay. We all know somebody who's had cancer.
Oh, yeah.
Okay. And I just applaud these companies for continuing. In fact, this company, Amneal Pharmaceuticals, this is their third MAB to be approved.
This year?
Yes.
Wow.
They're on fire.
Oh,
all right.
Great.
Okay. So it's just giving us more medications for serious indications. Okay.
Yeah. Yep.
So, all right. I mean, and like these drugs are used in combinations with other cancer medications. But the bottom line is, again, as that person in my audience said, what about the immunosuppressant? Your patient will be immunosuppressed on these medicines. So, if you do some form of treatment, and you will treat these patients, Jay.
Oh, yeah.
All right. A toothache does not discriminate, my friend. You know that.
Nope.
Okay.
Everybody gets them.
And we got to be ready to take care of these patients. And so, again, antibiotic coverage as well, too.
Yeah. Good.
All right. What's next, Jay?
Move on. Well, we've got Tlando.
Tlando. What is Tlando?
Tlando is a testosterone capsule, and it's used for basically testosterone deficiency.
Okay.
Mostly in men. It's what's interesting is this is a capsule. Most of the testosterone formulations are either a transdermal patch or a cream or an ointment of some sort that has to be put in a place that is not going to rub off during the day, and you've got to be careful not to touch the area. You've got to be careful not to let your skin in those areas touch someone else while you're using this. So the capsule is really a breakthrough, because the reason that we had all these transdermal systems was because it was broken down, and the testosterone was broken down in the GI tract. And I guess they've found a way for that not to happen with these testosterone capsules. So it's basically indicated for those who have deficiency or absence of endogenous testosterone. And testosterone, as we know, is a very important male hormone, and it's in females too, for defining sexual features. It helps build muscle mass, helps with development of red blood cells, contributes to bone density, also contributes to a sense of well-being, and also, of course, to sexual and reproductive function. So it's a very important hormone. And
Jay, I think it's great that they came out with the capsule, because also think about how many men patients will see in the office. They take a testosterone cypionate injection twice a month.
Yeah. There's also the little implantable capsules.
That's right.
Little pellets.
Pellets.
Yeah, that's
correct.
Pellets. Another way to go.
Right.
Yeah.
So
just to bypass the GI tract.
That's exactly right. Okay. Yeah. So now it's like, I have a section I talk about also about hereditary angioedema. All right. Well, the treatment for that was only these injectables. Well, finally, a company came out with a capsule for the treatment of HAE. Okay. So again, now here is something, instead of men or women having to get injections every 2 weeks, now you take a capsule. All right.
Yeah.
Just like the same thing we talked about with auto injectors, Jay.
Right.
Those days are coming to where all of them are going to be a nasal spray. All right.
Yeah, that would be great. So, testosterone deficiency affects a large amount, about 40% of men who are 45 and older. The levels start going down around age 30 and go down by about 1% or more every single year. So in patients over, especially in their 60s and 70s, testosterone deficiency is a major health issue.
And so no more shots,
No more shots. Yeah.
Well, if your healthcare provider will go that way,
Yeah.
but I mean, and now patients can ask for that. Hey, I want a pill now. Okay.
Yeah, exactly. They have another option open to them.
Yeah, that's awesome. All right, what's our next one?
Next, we have got, let's see, lots of notes here. We have got Pluvicto, which actually kind of is in the same, we sort of have a male-centric list of drugs tonight. Pluvicto is for metastatic prostate cancer, a specific type, a prostate-specific membrane surface antigen positive metastatic castration-resistant prostate cancer.
Wow.
And so it's actually a fairly common, in fact, the prostate-specific membrane antigen is fairly common. It's in about 80% of prostate cancers. And so what this drug does, what it is, and the generic name is lutetium Lu 177 Vipivotide tetrazetan, which is a mouthful.
That is.
But what it is, it's actually two drugs. So it's a ligand which basically binds to the cancer cells, along with a radioactive isotope. And the radioactive isotope then is directed specifically, it's targeted treatment for the prostate cancer. And so it goes right to where it needs to be. And so it's really kind of a big breakthrough in treatment that you can combining these two agents to be able to have such a specific treatment. Now, about 270 new cases of prostate cancer occur every year in the United States, and there are about 35,000 deaths per year in the United States due to prostate cancer. But most prostate cancers aren't lethal. Most of them are smaller, and they tend to grow very slowly, and so a lot of them don't have any symptoms at all. Others can be more aggressive, but as they get more aggressive or they get larger, you start having symptoms very similar to benign prostate hypertrophy, like difficulty urinating, decreased force of stream. Although not in cancer, not like in BPH, you may have blood in the urine, blood in the semen. You may have bone pain if there's metastases. Weight loss, another cardinal sign, or ED. So it's very late stage sometimes by the time it's diagnosed, unless you're going in for a regular physical exam and regular prostate exam.
Now, can you also use another cancer agent with this, or is it strictly just solo?
It's just the one agent. It's a radioactive.
Fascinating. Okay.
It's a radioactive agent that basically binds to the cancer cells. And what's interesting is for those who've had this treatment, they are advised to stay away from their family members, at least 6 feet away from their family members for at least 3 to 4 days, because they're radioactive.
Wow.
Yeah.
So bottom line is there is just a resurgence war on cancer. Okay.
Yeah.
I mean, look at the agents we're talking about already.
Yeah. And this drug appears to be very effective. If you look at kind of standard of care with some of the older medications, for severe or for more severe advanced cancers, the treatment rate may be as low as 2%, but they're seeing a 30% response in the patients who are taking Pluvicto.
Great.
Yeah. So that's really good news. Let's see, what else can we talk about with that? Well, that's basically it. It may cause some low blood levels, low blood cell counts. It may actually increase. Let's see, increasing the risk of blood clots. No, that's another one that we're talking about. So it could increase or it could decrease your blood levels because, again, it's a radioactive agent.
That's right.
So, yeah. So the next drug that we're going to talk about is Locametz, and this has a very apropos name because it's basically designed to locate metastases. And what is it used to locate metastases in prostate-specific membrane antigen prostate cancer? So what this is a radioisotope, and it's gallium Ga68. And what it does is it targets those membrane positive cells, and lets the doctors know, is this a prostate cancer that is going to respond to Pluvicto? And do they have metastases, or do they have recurrence of disease if they were treated previously? So it's both of these drugs are sort of used together in a sense. The Locametz to make the diagnosis of appropriateness of using Pluvicto, and then the Pluvicto for actual treatment.
So, Jay, the thing about using Locametz, it is used for a PET scan.
Right, for a PET scan.
PET stands for positron emission tomography. Okay, right. So many of our colleagues out there might refer somebody with oral cancer, and then they go in and get their first scan, but then the radiation oncologist may want to do, or they will do, a PET scan to see if any of the areas light up hot.
Right.
All right. So does that mean, is there a metastasis somewhere as well? Too?
Exactly.
So
not only will the prostate light up, but also you're looking for metastases or recurrent disease.
But right here with Locametz, Jay, this is more of a targeted therapy just for prostate cancer.
Yeah, it's more of a targeted diagnostic aid.
Yes, yes. So, I mean, wow. I mean, both these drugs came out the same day from the same company, but look at the benefit that they're going to have.
Yeah. I think the Locametz came out a couple of weeks later, but than Pluvicto. But they're both by the same company, Novartis. And so for men who get prostate cancer, this is a big breakthrough. Big breakthrough.
Okay.
All right, what's the next one?
Is Xelstrym with his dextroamphetamine. Okay, so when you hear dextroamphetamine, you're thinking something probably already related to the ADD or ADHD.
Right.
Disorders,
and that's exactly what it's for.
That's right. But it's not a pill, it's a transdermal system. Okay.
And we talked about a transdermal, was it 2 weeks ago or 3 weeks ago, for some psychiatric disorders.
That's right.
Yeah. I think for schizophrenia.
Yeah. And so again, we're starting to see, like, because again, some people just cannot swallow pills or have a very difficult time with this.
Or they forget. They
forget.
They can just put on a patch and leave it on for 2 weeks or 3 weeks, however long it's good for.
That's right. And this is indicated for children 6 and above. Okay.
Yeah.
All right.
And so there's about 6 million American children aged 2 to 17 that have received a diagnosis of ADHD, which is higher in the U.S. In fact, in more higher income countries, the prevalence of ADHD is actually higher than in lower income countries. And in the U.S., it's about 9.4% of this age group, 2 to 17.
I read a little comic strip one time. It said, back in my day, whenever we had all this nervous energy, my mom and dad said, just go outside and stay outside till it gets dark.
Yeah,
all right.
Exactly. Yeah. Well, ADHD does carry into adulthood, and in the 18 to 44 range, the current prevalence is about 4.4% in the U.S., and that's fairly recent numbers. And the lifetime prevalence is about 8% in the 18 to 64 age range. So very common problem.
You're good to go.
Yeah. So, but as this patch is not a benign drug. It's classified as a Schedule II because of the abuse potential, and it also can interact with a number of other drugs. And some of the drugs that it interacts with, we've discussed before, are some of the antidepressants.
That's right.
Okay. Or drugs such as trazodone that are serotonin enhancers. And same thing with tramadol, which is also, it was a pain medication, but also increases serotonin. So one of the big things you have to look out for in patients who are using this patch or dextroamphetamine pills for treatment is the serotonin syndrome.
Yes.
And we talked about that before. That's from basically very high levels of serotonin in the system, and the patients become very agitated, confused. They may become tachycardic, dizzy. They may flush, have tremors, even seizures. They may have a increase in their blood pressure, which can cause can actually lead to a stroke.
Oh, absolutely.
Nausea, vomiting, diarrhea, all kinds of things. So you really have to be monitoring patients well when they're taking both these drugs. So a patient who's on dextroamphetamine. So if you've got a patient in your practice who, whether they're using this patch or whether they're taking dextroamphetamine pills, and a lot of us have kids in our practice that come to see us who have ADHD. You got to be really careful about what pain medications you give them. So you would not give them tramadol.
Right. But if you do, you also need to alert their guardian or their parents right there and say, hey, look, I'm trying to stay away from the opioids. I'm going to give this. Yeah. So if something were, just call me if this were to occur,
Right. So, exactly. And take them right to the ER.
Absolutely.
If you see that. Yeah.
Absolutely.
Don't just call me, but yeah, exactly.
So again, knowledge and information is power.
Okay? Oh yeah, for sure. And the last drug that we're going to talk about is Hyftor. And what is this?
Oh, I love it. It's a treatment now, Jay, for facial angiofibromas associated with tuberous sclerosis.
All right. Those are pretty big words. What does all that mean?
But this is an mTOR inhibitor, which is also an immunosuppressant, and we've had other mTORs on here before. Okay, and so this is associated with facial angiofibromas in adults as well as pediatric patients, basically 6 years and above.
Yeah.
All right.
So tuberous sclerosis is basically this disease where you have benign sclerotic tumors all over the body. They can be in the skin, they can be in organs, they can be in the heart, they can be in the eyes, they can be in the lungs, just about anywhere, even kidneys, heart. And the symptoms depend on how many of these you have, how big these lesions are, the size of them, the number of them, and where they're affecting. Now, some people are very mildly affected, and it's not diagnosed until they become adults, and others are very severely affected, and it's diagnosed in early childhood. And one of the characteristics of the tuberous sclerosis are these facial angiofibromas, which are exactly what it sounds like, a fibrous mass with blood vessels.
Yes.
And especially, they can occur on the face and give kind of an acne type appearance. And patients who have these are very, very self-conscious because it's pretty noticeable.
That's right. Now, again, okay, so this is a topical gel, but it's a very strong topical gel. It's a significant immunosuppressant, like our JK inhibitors, Janus kinase, when we talked about atopic dermatitis. Okay, so I'm putting on a cream, no big deal. Yes,
but it gets absorbed.
A big deal. That's right. It gets absorbed. Yeah. So, you're not going to get yourself in trouble if you prescribe some antibiotics, as long as they're not allergic to that antibiotic, Jay. Yeah. Okay. All right.
Exactly.
That's how I look at antibiotics. I mean, because I'm not going to overuse them. You aren't going to overuse them. But before I prescribe them, I'm sure enough going to do a timeout to make sure that patient is not allergic to that antibiotic.
Yeah.
All right.
Yep. So the tuberous sclerosis, there's two forms. One is basically formed by a mutation in the tuberous sclerosis gene, one or two gene, or by inheritance. So it can either start in your generation or it can be passed on to others. Your descendants.
I'm just thankful for all these companies that are creating
these
all of these medication
orphan drugs.
systems.
They call them orphan drugs.
That's right. Yeah, and whether they're injectable, transdermal, PO, nasal, look at what's coming out, Jay.
Yeah.
It's just great stuff.
Yep.
All right. So let's
move on. Because we've been talking for a while.
I spent some time on this also in my lecture talking about heart failure, because a fair amount of our patients are going to have heart failure. And, there's, I may bounce, I may bounce around a little bit, but like I always try to tell people about, acronyms. If they say CHF or HF, they want to talk to them and try to find out more about, okay, how significant is this? Because this is a patient red flag when a patient comes into your office there. And you need to be able to ask them, hey, what is your EF? Ejection fracture. Okay. The lower the number, the higher the risk. Bottom line. Okay.
The patients generally, they get an echocardiogram, and that's how that's determined. Or a stress echo or an echocardiogram will give the ejection fraction.
And so, the number basically tells you how much blood your left ventricle is pumping to your body. Okay.
Yeah, it's what the ventricular volume of blood is versus what's actually pumped out.
That's correct.
What goes into the system out of that bag.
Right.
And that's the ejection fraction. So normal ejection fraction is about 50, 60, 70%. But patients who have congestive heart failure, it can be, it's significantly lower, like in the 30s or 40s.
Correct. All right. And so, Jay, there's a stage A, B, C, and D.
Yeah.
And of course, as you go down in the alphabet, you go down in the EF as well in those patients, and so with your left-sided heart failure, you're going to have either a reduced left ventricular function or a preserved left ventricular function. And then you can also have right-sided heart failure as well too.
Yeah. With the decreased left ventricular function, that's where you've got basically the muscle is not squeezing hard enough to get the blood out. When you do have the larger ejection fraction, or you have stiff walls that don't expand, and so the blood gets pumped because you still have the muscular strength, but the heart doesn't get a chance to fill as well because the walls are not as elastic. And that both of those categories, both of those, left heart failure is probably the most common thing, common etiology of right heart failure. And these are the patients that we see in our office that have the swollen legs and they can't lay flat. They have what's called orthopnea, which means basically straight breathing. Ortho is straight, and pnea has to do with breathing. So these patients, if you lay them flat, they can't breathe. They basically need to be sat up for dental treatment. And you can get a good estimation of how bad their orthopnea is and how bad their right heart failure is by asking them how many pillows they sleep on. So if they sleep on one pillow, they're maybe a little bit like this. If they're on two pillows, they have to be a little bit more upright. 3 pillows, even more. In fact, in medical practice, that's known as one pillow orthopnea, 2 pillow orthopnea, 3 pillow orthopnea, et cetera.
And Jay, we have to be careful starting an IV on these patients because we cannot fluid overload them, or we'll put them into congestive heart failure as well too. And so,
that's for sure.
But like stage A is considered pre-heart failure. It just means you're at a high risk of developing heart failure because you have a family history of it, and you have one or more, such as hypertension, diabetes, CAD, metabolic syndrome, and then when you get into
no symptoms.
That's right.
Yeah, and I've heard that they're actually starting to use some diabetes medicines to treat congestive heart failure.
Yes.
Yeah. Drugs like Jardiance, Invokana, and these are sodium glucose co-transporter 2 inhibitors. And so basically the co-transporter basically transports the glucose and sodium together. It's a co-transporter through the blood. And what these inhibitors do is they cause the kidneys to remove both blood sugar, because they're anti-diabetics, but the sodium along with it.
And this new off-label use, and it is an off-label, okay?
Yeah.
It is found to lower the risk of death in these patients as well. So I applaud the American College of Cardiology going out and saying, hey, we need to use these medications because they release new guidelines on that. So
yeah, I wonder how they discovered that. I guess diabetics tended to have lower blood pressure, or because I thought they all had higher blood pressure from what I've seen. But yeah, it's interesting. And there, a number of classes of medications that are used for treating congestive heart failure, like ACE inhibitors, angiotensin, angiotensin receptor blockers, and then these drugs known as ARN inhibitors, which are angiotensin receptor neprilysin inhibitors. And this is a combination of valsartan, which inhibits angiotensin 2, which leads to dilation of the blood vessels, along with sacubitril, which blocks the breakdown of natriuretic peptides. And this causes sodium and water to pass into the urine. So it reduces preload and afterload for the heart.
Awesome stuff.
Yeah.
So we'll just pick up on heart failure in 2 weeks. And
Sounds good to me.
When we return.
We talked about stage A, so we'll pick up with stage B when we see you all next time. So we bid you farewell. We hope you have a nice Easter and Passover, and we will see you back again on April 28th. April 28th, same time, same channel. Until then, be safe and be sane, and we will see you in 2 weeks.
Thank you, Pharma Nation. Have a good night.
Bye-bye.
Bye-bye.